Hello, my name is Miguel Stanley from Lisbon, Portugal, and welcome to Dental XP. I'm here today to talk about a technique, one of many techniques to help regenerate the soft tissue and the bone around large defects in the aesthetic area. A problem which we have every day in our practices, and I think that the word of this century in our field is speed and predictability, and this is something that me and my team have been striving to do, and I'd like to show and share with you a technique that we've been developing here in Lisbon over the last 2 years. Before we do that, let's define a couple of paradigms that define a smile. Very basically, we have a low lip line, average normal lip line, or a high lip line. These high lip lines usually present the highest degree of difficulty because we're not allowed much leeway in these cases, and we really have to be careful with what we do. Of course, we also have to take into consideration the biotype. If we have a thick biotype and thick tissue surrounding the teeth, it's usually easier for us to work than as opposed to a very thin biotype. So of course, the hardest cases will be a thin biotype, a high lip and smile line, and no solution but extraction in the anterior region. Now, being an implant dentist and also a cosmetic dentist, I have this paradigm. I love to place implants, but I also like to have an overall aesthetic result. And despite great advances in the implant field, and we'll see a bit of this later on in the lecture, I will always prefer to save a tooth in the aesthetic area. And we have a great endodontic department in our clinic, and we always try and rely on them to save these teeth as much as possible using microscopic endodontics, but sometimes we can't really do that. So why would we ever want to extract teeth in the aesthetic area? Well, there's a few reasons. Root fracture, endoperio failure, surgical failure, and root resorption are a couple of situations that would require tooth extraction. So we do this, and here you can see a photograph of the extraction of a tooth, but this is something that we should always try and avoid. But how do we manage situations when tooth extraction is the only option in an aesthetic area with a high lip line and a thin biotype? And a very large bony defect, as you can see in these cases. I mean, we're talking very large loss of vestibular and horizontal bone underlining this problem. And we can define these post-extraction defects in many ways, and we'll see that just now. But let's first go into what happens to the bone morphologically after a tooth extraction in just a natural case. I mean, studies since 1969 until recent days show that up to 50% of that bone will be lost in the first 12 months. That's up to 5 to 7 millimeters of horizontal volume reduction. Not so much the vertical, but the horizontal reduction. And if we don't do anything following extraction, that will probably leave a depression in the aesthetic area, which will leave a shade and consequently be anesthetic. When we go into these cases, preparation is everything, and of course we can use a CAT scan or simply CT probing when CAT scan is not available. But the reason for information and the reason for all our education and the reason why we come to Dental XP and take our degrees and our courses is to be prepared for these situations. And many times when we take a tooth out and we think we're just going to have simple extraction and we could do an immediate implant, and we find these very large bony defects, I find it imperative to have solutions, and simple solutions and credible solutions that will give our patients a predictable overall result. So why would we not do an immediate implant in these large class 4, let's call these class 4 according to Fanato, these class 4 bony defects? Well, we know that the first thing for success in an implant is primary stability. We could probably get primary stability in a lesion like this, but would we angulate our implant correctly? No. Now we know also that to have an overall longevity on this implant in an aesthetic and a functional way, we have to have our implant placed correctly. So yes, sometimes we could get primary stability, we could do some immediate grafting using any material, but that implant would not be correctly angulated. And we are, once again, working in an aesthetic zone, high lip line, thin biotype. So how are we going to manage these very large buccal plate defects? So there are a couple of solutions. Of course, we can use a flap or a flapless technique. Now remember, once we discover that we have a class 4 lesion following extraction, we then have to immediately go into delayed implant placement. So this lecture is not about immediate implant placement, which you can see some wonderful presentations throughout Dental XP from all over the world. This is a delayed implant placement technique. Now, we can use autogenous bone or xenograft, membranes. What I'd like to discuss is a couple of solutions. So if we use a full flap approach, we have a couple of advantages. A, we can really take a good look at the size of our defect. We can make sure we clean it properly, and we can use a membrane to hold our allograft in place. Now, we know that we might lose some horizontal depth, some horizontal width throughout the healing process of the subsequent 5 to 6 months. So the titanium reinforced membranes are very good to maintain a dimension. And there are so many brilliant cases that show great results with this. But once again, if we have a thin biotype and we have to raise one flap to do the surgery and then go back to remove this membrane, not only is it more invasive, but we have quite a large risk of gingival recession and subsequent aesthetic failure. So we have to always take this into consideration with the full flap approach. If we do a flapless approach, we have another set of advantages. We have a less invasive procedure, less trauma and less bone loss, because basically we're keeping the periosteum in place. But we can only really guarantee minor defects, and we won't be able to be using a collagen membrane, which would help maintain, with titanium of course, to maintain horizontal dimension. So there are advantages in one technique and there are advantages in another, and both carry their disadvantages. So the dilemma is, if we raise a full flap, we get a good correction of the tissue defects, but possible gingival recession. And if we do a flapless, we don't really have the guarantees. So my question I was asking myself was how we can combine the best of both worlds. One-stage surgery, predictable maintenance of both horizontal and vertical bone, and soft tissue preservation in these very large defects in the aesthetic area. Now, we have seen the work of Dr. Steigman with his aesthetic buccal flap with the following immediate extraction and immediate placement. And it works. It's a great technique. And I was wondering, well, I can't place my implant immediately. I can't be doing any grafting here. So what can we do with these things? So we developed this technique following simple procedures that are already in the literature and most of you are aware of. So we just take the tooth out, and this is not a case per se. This is just a generic flow of some slides to explain the technique. We raise an aesthetic buccal flap, as described by Steigman, leaving 3 millimeters to the gingival margin, so we won't have an aesthetic complication in the case of a thin biotype. And of course, then we expose the full size of the defect. We probe it, we scan it, we clean it, and then we fill it. Now, this is where it gets interesting. What we do is we get an autogenous bone graft from the mandibular ramus, a nice a trephine that is measured before to the size of the alveolar socket, and we get this cortical bone graft. We will then fill the defect with bio-os, or an autogenous, mixed with autogenous bone as well, and we will place that into the defect, and we use this cortical bone graft that we've harvested from the ramus, and we actually plug that into place. That is wedged into place in the socket, and you can see in these images the cortical facing upwards. And here you can have a nice image of the particulated bone allograft and then the subsequent collagen membrane protecting this graft only on a horizontal level. We do not need to bring it through to a vertical standpoint because we have the cortical bone. And one of the wonders of this, as you can see in the subsequent X-rays, is that we can leave that cortical bone at the level of the adjacent teeth, and that will give us an overall aesthetical result. In order to cover the graft, we use a tissue punch technique. We can go and harvest this from the palate, or if you will, from the tuberosity, which is probably easier for the patient in post-op healing. We suture everything up with a 5/0 polypropylene nylon suture and hold that all nicely into place. We can use two types of provisionalization, a removable or a immediate provisional bridge, a Maryland, just a simple composite, making sure that not too much pressure is applied onto the gingiva in this case. Here you can see the post-op radiograph, and you can see a nice clean image of several things here. You can see the bio-os on a deeper level, the cortical graft which has been wedged into place at the same level of the adjacent teeth. Now, there are numerous studies in the literature that show that one of the overall outcomes, the overall desires for aesthetic outcome, is that the bone is at the same level as the adjacent teeth. And we can achieve this with this technique. And note that there are no screws, no membranes, and no need for any second stage surgery, because we don't need to remove anything else. And plus, with this wedge technique, we have managed to stay faithful to one of the main pillars of bone regeneration, which is primary stability of our graft, and it really does not move, so we have that quite protected. And as you can see, once again here, the different segments. So here we have a 6-month post-op image after the Maryland is removed, and note the volume, the horizontal volume of bone following 6 months. Now, if studies show, as we saw in the beginning, up to 5 to 7 millimeters of bone loss in the first 12 months, we should have at least 3 to 4 millimeters at this stage. And note, there's absolutely no loss of volume. And here we do just a simple tissue punch technique, place our implant in perfect angulation, and get a provisionalization. We like to use screw-retained provisionalizations here. This is an immediate provisionalization, immediate loading post-op, and we can take a definitive impression on the spot, if you will. And here we have the zirconium copings and the full ceramic rehabilitation. One of the things we also like to include in our clinic is these studies that show show us how to create a papilla through the literature. So it's great studies since Dennis Tarnow up to the Salamas, who have created these studies that show us, to get papilla height, there are specific measurements that we have to be taken into consideration. And if you respect this, you really do get a wonderful overall aesthetic result. And here we can have the full ceramic rehabilitation of this case. Now, we're going to show you a couple of cases, but before, just a little sideliner here to show this new technology, laser lock technology, which actually has this special treatment on the implant, which helps the formation of supracrestal fibers. And it's just an added benefit for us working in this field to make sure that we can guarantee more longevity in these cases. So I'm going to walk you through a couple of cases to show that we've actually managed to repeat the surgery and get consistent good results with this. And I think that is the main aim of Dental XP, is that all of us globally can come here and share our ideas and share our thoughts and share our cases, and basically tomorrow or even the same afternoon apply this in our offices. So here we have a case. This is my first case, and I apologize for the photograph, but I didn't know yet that I was going to do this. I was actually planning an immediate implant following Dr. Steigman's technique here, and which I'd actually seen a week before in Miami. And here we have a patient comes in. My endodontic crew had said that there was no way to salvage this central incisor. And note on the image on the right side of your screen that the tooth in question actually had a longer crown length due to some gingival recession and bone loss associated to it. And remember this image because it will be important in the end. So I took the tooth out, and I was wanting to place an immediate implant with some minor grafting with an aesthetic buccal flap. However, I noticed that this was a class 4 defect and not a class 3 defect, and I would not get primary stability and good angulation of this implant. And immediately I was like, oh my God, what am I going to be able to do here? How to solve this problem? So this is where it all started. I went to the ramus, I got a nice cortical block, I wedged that into place. I placed some bio-os with a collagen membrane to cover up the horizontal defect, and a tissue punch technique with the gingiva, sutured it all up, and here we have the lesion all closed, no bone exposed. This is 3 weeks post-op. You can see the x-ray on your right, and following 6 months we placed an implant. This is a BioHorizons internal Prodigy implant. We use the actual abutment that comes with the system for an impression. This is following 6 weeks after implant placement. You can see that gingiva beautifully healed around the neck of that implant there. And this patient had, I'm going to go back one slide there, had multiple composite restorations on her front teeth, which she wished to change. So we decided to prep all these teeth at the same time. And here we have the try-in of the zirconium abutment, the ceramic try-in. We like to do this always to make sure that not only is the lab work aesthetic, but also functional and in place. And here we have the work cemented. And this is a 8-month follow-up of this case, and you can see absolutely no loss of volume. And I'll take you back to that study that we saw at the beginning of this presentation, that up to 5 to 7 millimeters of horizontal bone loss after 12 months. And remember the size, and that's on a normal extraction. We're talking about very large bony defects here without a second stage surgery. So here we can see a before and after photograph, and with some gingival contouring, we managed to get that all into place. Here's another case. A patient came in for some dental bleaching, and we saw this staining of the gingiva here. Following x-ray, we'd seen a tooth that had up to 3 apical surgeries here. This tooth had absolutely no way of surviving, so we proceeded with an extraction, raised the aesthetic buccal flap, realized we had a very large bony defect and also some regeneration material in the bone that hadn't integrated. So we removed all that regeneration material, and once again went to get the cortical bone graft, wedged that into place. And one of the great things about this technique is you can actually decide how deep you want to place the cortical graft. We placed the bio-os and the collagen membrane on the horizontal defect, sutured it all up, placed a Maryland composite bridge on the spot that was pre-made. And here we have 6 months post-op, placement of the implant using a simple tissue punch technique. This is a tapered implant, and the try-in, and here's the case cemented. And ironically, you can see this is the day of cementation, that the gum around the implant is actually the nicest one. Also on the photograph on the right, you can see the clinical aspect of us, the lab aspect, where we actually create the contact point according to the studies in the literature. And here we have on the day of cementation, and this is a 1-year post-op photograph on the right. And once again, absolutely no loss of vertical or horizontal bone. And Matilda, a young 16-year-old girl, fell off a horse in England, and here we have a natural diastema. This tooth had root canal despite the fact that the tooth was fractured and was splintered. This is a young girl that comes from quite a troubled background. Her family, she's one of 6 children. Her family suffered from ataxia, which is an organization I support in the UK. And didn't have a lot of financial capacities. And I met her one night and I said, well, why don't you fly out to Portugal and let us do this for you? And the mother said, well, we can't afford that. And it was our privilege to do this for her and for Ataxia UK. But I'm saying this because the child couldn't fly out that many times. Now, knowing that I would have a very large bony defect with the systems that are already in place and the techniques that are already in place, knowing that I would place a delayed implant. We're talking usually extraction, grafting, and the first stage surgery with the titanium membrane to keep the graft in place. A second stage surgery to remove the titanium membrane and the placement of that implant. Then a third stage to expose that implant, impressions, try-ins, etc. So I wanted to prove something to myself and to my team, and of course to the technique itself. And I braved it, and I said, well, let's try and do this in 3 to 4 consultations. And I knew it was a risk, but I'd done this technique twice before, and I believed it to work, and that's what we did. On the first day she arrived, we immediately took out the tooth. Despite having no CT scanning, we knew we'd have this technique, and a larger or smaller bony defect, we will treat them all the same. Aesthetic buccal flap, placement of the bio-os, getting the cortical bone plug, placing it into place, suturing everything up. This is the second appointment I had with her. She left from the first appointment with a removable denture. That was all we could provide because we had our lab make that on the spot. And this is following 6 months of the surgery. So this is the second time I saw this young girl. Immediately we placed the implant because the graft was perfect. We have no loss of bone. On the spot, using the abutment that comes with the technique, we took the impression. We like to use Improgam for these things, and made an immediate provisionalization, screw-retained provisionalization to make sure that there's no cement getting around our implant. Of course, one of the most important things is that this crown is completely out of occlusion and has no functional function, to say that, just for an aesthetic result. And she flew back to London. So that's 2 appointments. Then our lab proceeded to make the crown and the zirconium abutment at the same time. Usually we like to do this delayed. We like to place the zirconium abutment and take an impression and do that delayed. But we had a time issue here. So we did this all simultaneously. And remember, in the beginning, she did have quite a large diastema. And we didn't really get a chance to try in the color. But the third time that we saw this young lady, we tried in the zirconium abutment and we fitted it into place. And here you can see that the overall radiographic results is very good. However, on the left side, the aesthetic result could be better. But we're going to see this girl again in a couple of months, and we will then have a chance to fix this crown for her and probably actually keep the diastema, which I think she liked. But once again, this is about the soft tissue and the hard tissue and not about the crown itself. And I think in only 3 appointments to get a result like this is quite interesting. And she's actually quite happy. And last case, young boy, had some trauma to his 2 central incisors over 5 or 6 years ago. And one of his teeth, one of the central incisors, was presenting a slight fistula. We sent him to our endodontic team, and they said that there was no help for this tooth, that it needed to be extracted. I recall that we do not like to extract central incisors because it's always a lot of work. But now with this technique, we were feeling a lot more confident that we could do this. And once again, we're not so scared to do this anymore when we know we're going to have large defects. So once again, here we did a traumatic extraction, raised an EBF, an aesthetic buccal flap, and did some probing, took out all that residue, all the granulous tissue, measure the size of the alveolar socket with the trephine to make sure that the size of our graft is good enough to be wedged in, because remember, it cannot be loose. We get our bone graft, place the bio-os in the horizontal defect, and here you can actually see it coming out of the orifice, and then we wedge our hard cortical bone graft through the socket into a fixed position, pushing that granulous bio-os into its place. Place the membrane to cover that up. No need to bring it onto the cortical side. Get a tissue punch technique from the palate, put that into place, suture everything in place. He walked out with an immediate removable denture. Here is 6 weeks post-op. Notice the soft tissues, and thanks to the aesthetic buccal flap, there's no scarring around the teeth. And here we have a beautiful image to show the volume of all that tissue in place. And here again. So we then placed a Maryland bridge to wait for the 6 months. Being a young, active adult, we didn't want him to have a removable denture. And here we have, after some dental bleaching, that Maryland in place. Following the 6 months, here we have the photograph. Once again, I'll ask you to look at the size and the volume of that soft tissue surrounding the edentulous site. I think the images will speak for themselves. And after those 6 months, we do a tissue punch technique, and you can see here the cortical bone in place. And despite the irregular crest, with this new laser lock technology, we are quite certain that, as studies show, the supracrestal fibers will form not only naturally in the bone integration on the vestibular side, on the buccal side, but also on the lingual side, on the palatal side. Those supracrestal fibers will integrate with the implant as well. Here we place our implant. We immediately take an impression using the abutment that comes with the system. Immediate provisualization. Screw retained. This is immediately after the surgery, out of occlusion, no function, just aesthetics. And this is following 3 weeks of implant placement with a temporary crown in place. And here we have the day of the try-in. Look at the gingiva, look at the volume of that bone. Absolutely no horizontal or vertical bone loss. The impression, the lab. Here we have the try-in of the zirconium abutment. We weren't too happy with the anatomy of this crown. We sent that back to the lab, and here we have photos of the try-in. Now look at these side photographs. You can actually see there's no depression in that area, and here we have the final result. So I've walked you through this process step by step, and the overall objective here is to achieve health function and, of course, aesthetics, which is what most of our patients want. So I really hope that this has been helpful and something that you can apply in your day-to-day practices as of tomorrow. There's nothing new. There's no new science here. Everything has been clinically proven before in clinical trials and in articles published over the last decades. And I would like to thank a lot of people on Dental XP and around the world that have helped me and my team be able to be here today. So thank you very, very much. And feel free to visit our website, www.whitelifedesign.com. And in the future, we'll be bringing you some more cases to share.